It's a great pleasure to be here. Thank you very much for the invitation. It's a great pleasure that I can speak about the very old paper. I just came back from my research fellowship in San Diego, and when that was 2001 when we started to write that paper. The idea, the concept was from Norbert Bose. He was at that time the senior author. He's a spinal surgeon. Actually, he probably deserves the name for that classification. At that time, I didn't find that very exciting. I didn't find it very useful clinically, but I know it's a great research tool. But I'm fully convinced that we should stop to diagnose and treat patients just based on terms like mild, moderate, and severe. We should use terms that are reproducible, terms that should be measurable. We should have a common language. That's just not the way we should act academically. The basis of the grading was the Thompson grading, which is a gross pathology grading, and the idea was to translate that Thompson grading into a MRI grading using T2 weighted image. The base is looking at the nucleus pulposus. The nucleus pulposus in a normal patient has a lot of water and proteoglycans. So on a T2 weighted image, it looks like water. Vice versa, we have the annulus fibrosus, which is made from type 1 collagen. Basically, it is a ligament. So at MR, it is dark. So any high signal in a dark structure will be abnormal. So a bright signal within that ligament will be a tear. It's the high intensity zone, it's a ligament tear, it's the annulus fibrosus tear. When we grow older, the nucleus pulposus goes away, gets old, loss of water, and lots of proteoglycans. Disc grade 1, that's the disc that we have in a child or an adolescent. The nucleus pulposus is homogeneous, bright, and white. In the normal adult, we have a disc grade 2. We get little inhomogeneities, possible horizontal bands, but still the structure is bright. Later on, we lose signal, the signal drops a little bit, but we still have a good distinction between the nucleus and the annulus fibrosus. In grade 4, we have a band where we have no possibility to discern the nucleus from the annulus fibrosus, and grade 5 is the collapse of the disc. Here, some MR images, the grade 1, the adolescent or the juvenile disc with a bright homogeneous nucleus. Grade 2, the adolescent disc, the disc of an adult person, little inhomogeneities, horizontal bands, but still very bright. Grade 3, we lose the signal a little bit, but still have a good distinction. Grade 4, the band. Grade 5, the collapse. This is a wish list for a grading system. It's clearly not complete. The grading that we use for a disc degeneration should be reproducible. We just look into that a little bit, how our grading performs. It should be quantitative, and the Pfirrmann grading is clearly not a quantitative measurement, it's an ordinal one. It should be sensitive to early DDD. At least we included the very early stage, the adolescent disc. We should be able to identify painful disc. That's obviously not possible. Monitor therapy. If you have time enough, it is a good grading, but usually interventions are monitored through about 2 years, and that's not enough time for the Pfirrmann grading, because usually at that time, the grades stay the same. This is the intra and inter-observer reliability from the original paper, and you can see the kappa values are okay. Looking into details, you can see that for intra-observer, about 10% disagreement was there. For inter-observer, up to 20% disagreement was there. The performance is okay, but it's clearly not perfect. This has been repeated and re-evaluated several times. This is one of the papers coming to almost the same conclusion. Relevance of that disc degeneration. You all know that very well. This is from an old paper that we also did looking at asymptomatic spines. We could see that roughly 2/3 of volunteers without any problems have advanced disc degeneration grade 4 and grade 5. How about painful disc? This is a paper we also did at that time. We correlated disc morphology and adjacent findings to provocative discography. Well, at least we could say a normal disc on an MRI is generally not painful. However, disc degeneration, advanced disc degeneration, is clearly not necessarily associated with symptoms. So MR using just the morphology of the disc is unable to determine a painful disc. That's bad enough. So how did the paper perform? Well, we wrote that paper, and roughly 10 years, nothing happens. No citations. I almost forgot about that paper. But then it started to become popular for research, for monitoring studies, and so on. And actually, it became one of the most successful papers. It's actually in the 30 most common cited paper in orthopedic literature. Things happen. Well, lots of modifications were done, modified Pfirrmann gradings. There are a number of that. I just lost track, so many are out there. This is one of which I present here. Another one is the Griffith grading. Most of the modified grading add degrees in grade 3 and grade 4 disc to be more detailed. This is another paper that we did actually. We used a modified grading with 20 grades. Well, that's clinically impossible to use, of course, even in study setups. It's very, very difficult, of course. Why don't we just go and measure, have a measurement, a real measurement for disc degeneration? MR is a great tool for that, isn't it? Well, here we have the MRI setup. MRI is great for measuring all kinds of stuff. It's really a fantastic tool, but it has a lot of challenges. When you look at this image here on the left side and the image in the middle, it's the same image. Just window leveling is different. What you can see close to the coil, the receiving coil, we need a spine coil at the back to receive the signal from the body. So any structure that is close to that coil will have a high signal. Any structure which is remote will have a drop in signal. That means if you measure, for example, the fat in the subcutaneous tissue, it will have a lot of signal. If you measure the fat anterior to the spine, it will have only a little bit of signal, although it should have the same signal. You see, MR is very challenging, and you cannot just go and measure the signal and make it as a measurement for a disc degeneration. You make systematic errors. You have to go into detail and do mapping procedures. We have two targets that we can address with quantitative MR imaging. We have the water content and we have proteoglycans. For mapping, usually, you cannot do just a normal sequence, the T2-weighted sequence. You need to do multiple T2-weighted sequence with different parameters, and then you put all those pixels into an equation, and then you get real T2 times, and that is a parameter that can be used. You cannot just go, as in CT, we have Hounsfield units. That's a very calibrated unit. You can go into a CT and measure. You cannot do that with a standard MR image. I'm showing you some of the quantitative MR imaging methods. Here is an example. What you get as a result is a map with a colorful image like this. But whenever you see a disc with a color, this is a disc, is an image which was done by Photoshop, always. Why? The scanner never puts only the color into the disc. Some person had to cut that out and overlay it on that image. The scanner will put out an image like that. That's the original image, which is original from the scanner, not the one on your right. Here is T2 mapping. That's the probably most known method to look at the disc. The target is the water, and you can see it is well validated and it's easily available on most systems. However, scanning time is very long. There is another very similar method, which is T2 star mapping. The target again is water. The scanning time is shorter. However, it is very susceptible to field inhomogeneities. For example, post images are almost not possible to scan. This is T1 row, very interesting because the target here is proteoglycans. With this method, you can address the proteoglycans in the nucleus pulposus, which is very interesting. However, the cons are it's very susceptible to imaging artifact, and the reproducibility is very bad. So if you take a person, even if in the same time, 2 times in the scanner, will have different results. If you take different scanner, completely all over the place. So a method needs to be reproducible. You have to have the same result in one scanner, in the 3 Tesla, 1.5, in a different institution. If that's not working, this is rubbish. This is correlation of the mapping method with the Pfirrmann grades. You can see all correlate quite well. T2 mapping and T1 row a little bit better than T2 star. How about addressing the molecules directly? One method is looking at the sodium. Sodium is one component that is in the proteoglycans. With MRI, we usually measure the water, but we also can use the sodium as an agent. However, the problem here is sodium is just much less common than the water in the body, so we have much less signal. So for looking at that, we need high field strength 7 Tesla machines and long scanning time. So that's not readily available. How about MR spectroscopy? Spectroscopy is fantastic, looking at all the metabolites. It's very used in the brain for brain tumors. You can use that also for the disc. Here an example, in a normal disc you can see a peak of the proteoglycan and another peak in the degenerated disc on the right, which is much lower. You can look at other peaks reflecting the other components. So it really gives you an insight into the disc. Why aren't we using it? The problem is you have to put a voxel into the disc. If you have a collapsed disc, that's not possible. Even in a normal disc, you have to put a voxel inside. It will always be a little bit outside of that disc, so it will be contaminated by the adjacent bone and so on. So it is a difficult and challenging method. However, a very nice one. Coming back to the Pfirrmann grading. The Pfirrmann grading is a visual grading. And that's a task which is a very good use case for artificial intelligence. With artificial intelligence and deep learning, you can look at different structure and promote automatic grading. There are a number of papers having demonstrated that it is really easy. You can do that now with things that are readily available just on the internet. Here one example doing that, and the algorithm at the end gives you all the grades automatically. Having said that, I would like to conclude, and I would like to thank you very much that I could talk to you about a almost historic paper, and I'm happy that it's still in use and useful in nowadays practice. Thank you very much.
So thank you, Christian. Please come here for a short discussion. We maybe have time for 1 or 2 questions. Please go to the microphones or use the question and answer function.
Dr. Pfirrmann, my name is Derek Coley from Ireland. I note that the greatest area of inter-observer disagreement was between grades 3 and 4. There's a change in the histology of the disc there, I think, and certainly our group looked at CT scans of those patients and showed that the incidence of a vacuum disc was much higher in those with grade 4 compared to grade 3. And I would agree with you, we can't advocate doing a CT scan of the lumbar spine for something that we already know about. And in the research study we did, it was actually CT abdomens that were done in or around the same time. But they did significantly contribute towards a further discrimination of a not so bad disc in somebody who's a little bit older versus somebody who has significant advanced disc degeneration. So I suppose my question is, do you think that with the artificial intelligence instruments that we now have, that based on evaluation of what a CT scan looks like, could that help improve our analysis of MRI scans so that we're better able to predict vacuum discs on MRI scans in those with advanced disc degeneration?
That's a very interesting question. There are two things to say about that. CT technology is really advancing at the moment. We're getting photon counting CTs. With photon counting CTs, we can do material decomposition. There are already first papers out there looking at collagen content of the disc. So that will be an opportunity to look more in detail just using CT. And to use artificial intelligence to do what? What does
because we know so much about what it looks like, that we could use this additional information from CT to further advance our MRI and understanding.
Clearly, that's also something that it's feasible. If you have an MRI and the CT at the same time, you can use that as a source and the target and educate a neural network. That's possible. It's already done using, for example, MRI to make a CT-like image. So same can be done to for example, do a look at vacuum phenomenon on the vacuum disc. I'm sure that's possible. Maybe there's no solution out there clinically available, but that's technically, I think, should be possible.
Thank you. Okay.